Good morning and welcome to your vasopressor bootcamp, part 8. Today we are talking about a vasopressor that technically isn't actually a vasopressor, it's more of an inodilator, but it usually gets lumped in with the other vasopressors. So today's vasopressor or inodilator is Dobutamine. What's up you guys, it's your ER pharmacist Lil Pharma. This is our vasopressor bootcamp series where we're talking about all of our vasopressors, how they work, when to use them, when not to use them, and side effects associated with them. So let's get into it and talk about Dobutamine. Dobutamine is primarily a beta-1 agonist, so it really only hits those beta-1 receptors. It doesn't have any effect on the peripheral blood vessels that causing that squeeze or increase in blood pressure. So it's really just increasing cardiac output. It does have some effect at the beta-2 receptors, so understanding that there could be some vasodilation based on that, but primarily it's a beta-1 agonist, so it's going to increase heart rate, increase cardiac output. So this is great for our cardiogenic shock patients. We can typically add this on if we've already started norepinephrine maybe. We can add it on if we need more pump support. Another indication for this one is massive PE with RV strain. So this one we can, again, our first line vasopressor is going to be norepinephrine. But if we need more pump support, you can add on Dobutamine to augment that right ventricle output. If you have a combination of PE and cardiogenic shock, this can be a great agent to use. This is typically not our first line or even second line in septic shock because we have more of a distributive shock and we need those vessels to cooperate. So typically we'll add norepinephrine, maybe even epinephrine, but if you still need more pump support, you could add Dobutamine as an adjunct. And then an interesting indication for this one in beta blocker or calcium channel blocker overdose, if your initial agents haven't done the trick, your high dose insulin, glucagon, maybe calcium, you can add on Dobutamine to your initial vasopressors for that extra pump support. When not to use Dobutamine, so any sort of outflow tract obstruction is just gonna make it worse. If someone's already in a tachyarrhythmia, again, will make it worse. Hypotension, especially that distributive shock where you need the vessel squeeze, this is not gonna help at all. Patients on beta blockers, sometimes this doesn't work as well because it has the exact opposite mechanism of a beta blocker. So you might want to try something like milrinone, which we'll talk about in our next video. And of course, hypovolemia, always going to want to correct that volume status before we add on agents like Dobutamine. So what are the side effects? Tachycardia, which again is usually the goal. So tachycardia, hypotension in some patients. You might see a little bit of vasodilation from that beta-2 activation, or a compensatory drop in the blood pressure due to an increase in heart rate. Can actually cause hypokalemia, and then you might see a tachyphylaxis after 72 hours of use, so people can build kind of a tolerance to it. So thinking of Dobutamine as our agent for pump failure, and it's not always our first line agent, but if we get to the point where we understand that the pump is the issue, Dobutamine is going to be your agent of choice. If you need both squeeze and pump action, you can pair it with norepinephrine. All right, that's what I got for you guys. Comment down below with anything I missed. Bye.